Oh, we're live. Hey. Well, good evening, everyone. How are you? Good. Welcome to the PerfWeb series show. I'm your host, your humble host, Joe Basha. Some of you may know me, some of you may not. Our program tonight is on ECMO and a whole bunch of different things. And I have with me for this program, Chris Loosby. Chris is sitting right here next to me. Chris, how are you? It's good to see you.
Good to see you.
And Chris is a perfusionist down at Memorial Hermann Hospital in the medical center, and they do a lot of ECMO. So I'm going to give you a presentation. And every once in a while through the presentation, I'm going to stop, and Chris and I are going to discuss some of these key points. We also hope, of course, that you use the YouTube chat and you call in and all that stuff. But let me get through my list of things that I have to do here first. Remember, this program is approved for 2.5 Category 1 CEU by the ABCP, number one. And to become a part of our growing community, I need you to do these things right now. First, I need you to subscribe to our YouTube channel. You subscribe by clicking, click this button. I also would appreciate it if you would go on our website and download our flyer. You can find that on our perfweb.us website and click the menu item that says download flyer. Also, please like us on Facebook. Here's our thumbs up. That's that. Let's see, I think we have a thumbs up somewhere in there. Facebook thumbs up. There it goes. All righty. And to call in, please wait until you see this notice, which tells you the phone lines are open. And you can call that number, 281-738-7906, and be part of the conversation this evening. We really want to hear from you, all right? So call in. Don't be shy. You can also use the YouTube chat feature, which will be shown here. Keep in mind, you have to have a Gmail email account in order to be able to subscribe and also use this chat feature. So try to get that between now and the time I get this presentation started, and that way you can ask questions on YouTube chat as well. I've already sent you a good evening message that you should be able to see on there. And that YouTube chat feature was really popular during the New Orleans conference in June. We had a lot of, they were talking to each other back and forth, which was really kind of cool. And I hope that we get this community built in such a way that that actually happens as well when we do these PerfWeb webinars. And the goal here obviously is to try and accommodate those of you who can't get to a meeting. Chris, there's a lot of people that can't get to a meeting. And there's either CEU budgets have been cut, they don't have enough staffing, they just can't get away.
A lot of ECMO.
A lot of ECMO, exactly. We're going to talk about that tonight. Yeah. And what do people do? They try to go to a conference that's being live streamed, and right now there's only two. There's mine and there's the Sanibel that's being live streamed. But are you really going to sit there for 4 hours or 8 hours in a day and watch all of those presentations?
Probably not.
Probably not. So, this I hope is at a convenient time so people could get home, be done with work, or maybe even watch it from work if they're at the pump room or whatever it may be, and get the call room or wherever it may be. Okay, that reminds me. We have mugs, okay? And I remember the last webinar, I talked about this on Tuesday. These are very stylish mugs. Everybody wants one. Chris, you want one of these, don't you?
Absolutely.
You're getting one too. That's a party gift. Okay, we give that to everybody. And we are sending them out to all of you who have either YouTube chatted or called in. And I know there's a list of you that need them, but I promise you they are going out tomorrow. I wanted to wait until this program to send them all out so that I could add more to it. We want to give these mugs out because these are really nice. You can put your favorite beverage in it. You could put tequila, you could put coffee, you could put tea, you could put Coke. You can put anything in it, really. Scotch.
Pencils on my desk.
Well, exactly. And no one would know. So you could be at work and you could have your favorite liquid libation and they just think you're just very educational.
That's it.
And you could be sipping it so that you can go watch yet another ECMO.
Another one.
Another one. They're always coming. Okay. So let's get the show going. Again, it's on ECMO. Some of the ways we use it, some of the ways we cannulate, what the indications are, what the problems are, why do we do it, and what patients are best suited for it, and then is it really even economically viable to do it? Does it really benefit anybody? I think there's a lot of debate. I have had people tell me no one has ever been saved by ECMO. I've actually had people tell me that.
Well, obviously we know that's wrong, or we wouldn't be doing it. I've seen them. I've seen their stories, so I know that it saves lives.
Absolutely, I agree with you. But I think it has to be, you have to select patients properly, and you have to have a medical director, you have to have a perfusion director coordinator, and you have to have the resources in the nursing at the bedside that knows how to manage, who know how to manage these patients, or you will not save anyone with ECMO.
Yeah, truthfully, with ECMO, it's not just, oh, I need ECMO, I need a perfusionist and somebody to put it in. It really is using the entire team, you know, down from your pathology all the way to the surgical, cardiology, perfusion, nursing, respiratory. It really is. I mean, it really is to have a wonderful program. It's more than just putting somebody on a device and saying, okay, now save their life.
Right.
You really have to collaborate with an entire team to make it a successful program.
And I think, you know what, at the end of the day, I think that's the key takeaway point of this
It really is, yeah.
And we're going to probably say that again as we move forward. Okay, let me pull up my presentation on my computer as well. And all right, so let's just go ahead and get started. First of all, ECMO is here to stay. It is not going anywhere, all right? Not only has it increased this 433% between 2006 and 2011, let's look at this. These are ECMO centers. Now, this is worldwide, but it is growing every single year all the way through 2017. And actually, this slide is a little bit it's well, maybe even a lot underestimated, because this is only ELSO registered centers. There's a whole host of programs out there that are not ELSO registered that are also ECMO programs. So this is really an underestimate of how many programs really do exist right now in the world, and of course in the country. The United States is really the biggest consumer of ECMO services. In addition to that, the ECMO market size projection. Now, this is ECMO machines. They're saying is going to continue to grow, and I think the growth rate was about 15%, but it's going to reach $346.1 million by 2024. And all you have to do is look at LivaNova's purchase of Tandem Heart.
Correct.
Just happened. And they did that for a reason. They're trying to position themselves strategically to be able to offer both ECMO and cardiopulmonary and valve, but they added that ECMO component. And they didn't do that because they think that ECMO is not going to continue to be used and survive, right? And I don't have slides of this, but you know, I will talk about the cost here in a second. But I've shown the slides before. I guess I just didn't want to show them again. But in Paris, they're actually putting patients on ECMO on the street, in the grocery store, in the Louvre. And so they have ECMO specialists who are going with the ambulance, who can run the devices, and also physicians who can cannulate. And because they're recognizing that the sooner you put it in, the better chance that patient has to survive. And I've got some data on that that supports that idea.
Okay.
So here is some costs. And this is something that can be very difficult for a lot of smaller programs to be able to start up, depending on what you know, who you know, and what company you believe is the only company that can provide ECMO services. If you look at, for example, the Centromag, the device to drive the Centromag is about $43,000, and that's about what it costs for any standalone sort of centrifugal pump system that even LivaNova would have as a trolley or whatever, which is what we use.
Right.
So that's fairly normal, but it costs $12,000 and $2,000 for the pump and the oxygenator, to be able to put in line. So it's a $14,000 per patient cost just for the disposables portion of it. That's pretty steep. The Rotaflow, forget the second one over. Let's just look right at the ICU package. Is about $2,400. And of course, we're all familiar with the Rotaflow. Basically, it's just it's a centrifugal pump. If you don't know what it is, it's a centrifugal pump that it's suspended. It doesn't have bearings, and so there's a lot less heat generation. Much better for blood components long term. It doesn't get as hot. And then you have the Mackay Cardio Help, or Getting, or however you say the name of that company. They're $110,000 per device, and it's $13,781, so just about $14,000 for the disposables for that device. For Memorial Hermann, the Woodlands, the Med Center where you are, that's not too bad. But for a community-based hospital that may be in Alexandria, Louisiana, where there's no university hospital anywhere around, and maybe they only do 3 or 4 ECMOs a year. They want to put it in, get the patient stabilized, and then maybe life flight them out down to Oxygenation or whatever. They look at that amount and they go, there's no way in heck we could buy that.
You're right. So how I would look at this, first, one, I'm not a business owner, so honestly, I don't look at the cost. I'm mindful of my hospital. I don't waste products. But when it comes to ECMO, if you're such a small center like that, we're all perfusionists, and we understand that we know how to do this. It's essentially you're taking a heart-lung bypass and condensing it. So how I would look at this, if I were a community hospital, you could either put them on big pump and wait for your life flight, or you could take apart your big pump and make an ECMO circuit. That would be more cost effective, because how I view ECMO is you're saving somebody's life. I don't go in there and say, well, let me see their face sheet and I'll let you know what we're going to do or not going to do. And so when it comes to this, we use Cardio Help, and we also use a Sorin pump. I think the Cardio Help, for how we do it, works, because 1 minute I'm in ICU, another minute I'm in a helicopter flying a patient back to another our hospital. And so it's very durable. So I like that. So
it's a good system. I agree with you. It's a great system. And actually, I've got a slide that shows how that system has a lot of safety built into it, which enables other than perfusion to watch it. It's an interesting slide, and I think you'll have some good commentary on that too. But you're right. If you can't be right there at the bedside with every patient, because you have 4 or 5 of these going simultaneously.
Correct.
You can't be in every room at the same time. You have to have a device that is, for lack of a more eloquent expression, idiot-proof. You can't make a mistake and open a line that can put air into the negative side of the pump, because once that happens, the ball game's over.
Correct. Majority of the time, yes.
No, you ain't fixing that. Nobody's fixing it. If somebody opens a stopcock and completely deprimes it on a patient who is ECMO dependent, I think game's over.
Maybe you can still reprime. It depends on how well you know your pump. Because the Cardio Help has sensors. It's going to shut the pump off once it detects a bubble, and so it depends on how far it goes in the patient. Then we still mechanically look at it, plug lines in, and reprime the circuit. So I'm not saying it's 100%, but I'm not saying it's a game changer. We never give up.
No, I wouldn't give up either, especially if I'm the one who caused the problem. Yeah. But I know that the best way to avoid that is to not do it.
Correct.
And that if you don't have access, which their system does not have, that's the way it's designed. That's why it's designed that way. That was the safety portion of what I talked about. Let me get to that. So I think I did. Did I show that slide where it was the? This is the slide here. So let me go to this one here. So take a look at this slide. It's really interesting. In terms of how the companies market their product, the Centromag says that perfusionists can watch it, ECMO specialists can watch it, and bedside nurses can watch it. The same with the Cardio Help. But the Rotaflow and the Rotaflow ICU package, the bedside nurse is omitted from that. And I believe the reason for that is what we just discussed, safety. It's a safety issue. So simply by removing additional access to the circuit converts it from something that the bedside nurse can or cannot do. But it also changes the price point from $2,400 to $14,000.
That's a lot.
I'm still
That's a big
trying
difference.
to figure that out. Okay, but if you're going to be sending the patient on a helicopter, I've transported patients with the trolley that we tend to like to use with our system, and I can tell you right now, it ain't easy. Okay,
Correct.
Moving that trolley around is not. You have to go on an ambulance. It's not going in a helicopter.
No.
So, but if you're gonna be shipping your patient, and you're not going to be the ones doing the transport, then do you need? Wouldn't it be better to let you spend the $14,000 and come with that device and get them and switch them off?
Well, and that's what I was saying. If you're a small program and let's just say you have the approval, a physician that says, hey, we'll accept this patient, all these things, then put them on your heart-lung machine. Mm-hmm. I mean, at best, if you really think you need to be in the ICU and it's going to be more than a few hours, or you're waiting on somebody to come and get it 24 hours, then that's when you take apart or your pump and put them on something makeshift. I mean, we all know how to do it. We were trained to do that. But I wouldn't suggest a community hospital go out and spend $100,000 on a console plus a disposable just to do that 3 times a year. That's just not cost effective. And honestly, it's not really effective. If you're not using it all the time, then you're not going to be familiar with it, even the littlest thing. So even the perfusionist, they may be a great perfusionist, but they don't remember everything on your cardio help that you buy in January, and now here it is July, and you need to put it on somebody. Mm-hmm. You may or may not remember that, but your heart-lung machine that you use all day, every day for cases, you know where everything's at on there. Mm-hmm. So I would, for the most part, correct. So I would lean towards using that in these community hospitals. But in regards to it's going to depend on the size of your program. If you're coming from a program like ours, we absolutely need something like that. We need it durable. Again, helicopter, ambulance, whatever you're doing, or just going down to the cath lab, something that's going on, we need something durable. And I think it's a benefit to the patient and to the person watching the ECMO.
Well, do you have much experience with the Centromag?
I do.
Because that's pretty expensive, too.
It is. I mean, for that disposable, that's extremely expensive. And so I've used both. I still prefer the cardio help.
And it's just because they have the Levitronics pump.
Correct, that's it.
That's what the cost is. It's
Correct.
in the centrifugal pump.
Oh, and see, what this isn't taken into consideration is when you change out a circuit. So now you put this on a patient emergently. Now they have some type of coagulopathy, whether it be they need blood products or not blood products. And so what happens is now you clot this off. Now we need 14,000 more again.
Right.
Same thing on the other one.
Well, let's talk about that. Let's talk about what the impact of that is. So take a look at this slide here. And what you'll see, here, I got to use the right one this time. If you look right here, the average total payments, don't look at this number. This is what the average charges were, okay? Hospitals overcharge for everything, all right? This is what CMS, this is the average Medicare approved payment was to the patients here, over here, the 124, and to the hospitals. The 138 is average total payments, including private insurance. Mm-hmm. So on Medicare, it's 124,819. So it doesn't take a mathematician to start adding this up and going, holy mackerel, you know, we can destroy our budget if you're a hospital, all hospital.
Sure.
That's where most stuff happens. You know, you think the med center's huge. You guys are busy as can be, but we get an epidemic. Even you will run out of space.
We do it frequently, especially during flu season.
Right. And we're taking care of those patients.
That's right.
In the community setting, and they look at these numbers and go, well, wait a minute, Joe. I'm going to spend this much for the device, this much for the disposables. You might need 2 disposables for 1 patient because of all of these things you talked about. And I've got to pay you to sit at the bedside and watch it. Mm-hmm. Well, at day 15, all things being equal, we've already burned through 40% of their DRG.
Correct.
That they're going to get reimbursed. Right. And so they could get themselves in a lot of trouble.
You can. One perspective I would like to look at, again, for these community hospitals, you don't always have to buy it. And so I find if it were my program and I was comfortable with the device, I would rent the device, buy the disposables. Mm-hmm. Then as your program grows, then look into buying one.
Rent it from me.
Well, whomever has
Come on.
the point being is that if you want the best and you're like, well, we can't just drop $100,000 on a piece of equipment that's used 3 times a year, you can buy the disposable because you got to buy it anyway, and then you have one available for rental, paying that small fee because that $100,000 could last you 2 or 3 years worth of fees versus one payment.
Right. Or you use a hybrid system.
Correct.
That is just more affordable.
Correct.
And you say, you're very selective, those patients that you're going to keep versus those patients that you're going to ship.
Correct.
And you have to develop that network of the central hub and spoke and have that in place before you have a problem. I think what a lot of people do, a lot of programs do, is, oh, we don't ever see ECMO. Oh, we don't ever see ECMO. Well, you really should do this. Nah, we don't ever see ECMO. And that very same night, there's an ECMO.
Correct. You, as a program, you just need to decide what kind of program are you going to be. Are we going to be somebody, a Band-Aid until we can get them somewhere, or are we going to be a program that's going to grow and develop and save patients, put them on and take them off?
And keep them.
Correct.
And accept the good with the bad.
Exactly.
Because you have to
and
do
you
that
gotta,
too.
well, and you got to have a good outcome. Just because you put somebody on doesn't mean you can take them off.
That's right. Well, that's right. You put them on and you own them, and now you got a
Correct.
problem. That's right. So you really have to be careful about who you offer that service to. I completely agree with that. So let's look at some real data describing the cost effectiveness and benefit of ECMO. So, and this is published data. But you have conventional management, then you have the cost of the ECMO and what is its benefit. And how this is really explored and looked at in this particular study is QALY. And if you're not familiar with what QALY is a quality of adjusted life year. So how many years are you alive with perfect health? A QALY of 1 year of perfect health. So that's what you use to determine whether something is financially beneficial or not. And the conclusion of that study is in this graph here, and I think this graph just basically speaks for itself. There is no question that ECMO is a benefit to many patients. Not all, and it's not going to save everyone, and we can't save everyone. We'll talk about the survival going a little further in this slide. But based on this study that was done for economics to decide whether or not it is or is not worth it to use ECMO as a therapeutic modality for those patients that meet the inclusion criteria, it clearly does. I think it speaks for itself. Overall survival, VA ECMO is 40%, VV ECMO is 60%. Overall survival when you do not do VA ECMO is 0. Right. So if you say 40%, sounds like it's a low number unless you're one of those 40%.
Correct.
VV ECMO, if you do not do something with those patients, their survival is 0 or 60%.
Well, I don't know about the VA. I would agree with the VV. I don't know because some people still have a tendency to pull through. I see what you're saying, but you're looking at it this way. You put somebody on VV ECMO for ARDS or some type of lung pulmonary condition. What you're saying is you take them, you're cutting out that month in ICU on a ventilator in hopes they survive. And so instead you put them on here, you completely rest the lung, they recuperate 6, 8, 10, 12 days, now they come off. Versus you put them on in the hopes that they come off. We were going to put this patient on VV ECMO. We decided against it for whatever reason. And now they were in 6 weeks in the hospital, 4 weeks with us, trach to peg, shipped to an LTAC, eventually weaned off. So the VV, they can still possibly make it. But again, it just depends on at what cost.
Well, I think that's a good point. I think you just brought up a very good point, and I agree with you. I think that I did misspeak there. And I think that's been the knock for ECMO for many, many years. I've had people, I told you people have said no one's ever been saved with ECMO, but I've also heard people say for those patients that did survive, well, they would have survived without it. That patient would have made it without it. You put that ECMO in a patient that really could have done without it. And what I find is that people are afraid of clinicians, physicians who have to make the decision, they're afraid of the criticism of putting the patient on ECMO too soon, and then they wait and wait and wait and beat the lungs up for like 5 to 7
Yeah,
days.
absolutely.
And now their survival goes from 60% for VV down to 20% with VV.
That's always one of the factors right there is waiting too long. Because it's usually that last ditch effort, whether it's VA or VV, they're going to say, you know what, let's try ECMO. I personally believe that we wait too long. I believe a lot of the pulmonary patients are excellent patients, whether it's an asthma attack, pneumonia or something. I think you should jump in there sooner than later.
Smoke inhalation, sand inhalation. for
Absolutely, our
kids,
burn patients.
burn patients, anything.
Correct.
Yeah, I think it is. I think it's an underutilized tool. That's why I think it's going to continue to grow. And I think that we're getting better at patient selection. But I think we still have a long way to go in being able to identify those patients at day 2. I see where this is going. Let's go ahead and put the patient on ECMO now versus, well, let's wait till day 3. Well, it didn't get that much worse. Let's wait till day 4. And then day 5, they have peak pressures of 50.
Correct.
You got a pneumo now. You're putting a chest tube in. Their lungs are just
The inflammation is only going to get worse before it gets better from there. And you got to ask yourself, what is your end game?
Right.
VA or VV.
Right.
And so honestly, if anybody that's going in for a procedure, you need to ask yourself, if you're a big center anyway, is this patient an ECMO patient? I mean, if somebody's going in for a 3-vessel bypass, then you got to ask yourself, well, what is my end game? Okay, we're gonna refix everything that's going on here, and then send them home, or we're gonna go on bypass and they're not gonna tolerate it. And now we got to put them on ECMO and hope that they can come off. You got to look at everybody as an ECMO patient if you're going to have a big program. Do you have an end game for every patient?
Right. Yeah, I think there's a difference too. I hate to sound harsh, and I understand, anybody out there that might be, 85 years old, forgive me for this, but, I think there's a big difference between an 85-year-old who is not normally living an active lifestyle,
Correct.
who is coming in for a salvage procedure, lima to the LAD and maybe a vein graft here or there that cannot get weaned off pump or decompensates off pump and is not doing well, versus a 52-year-old who had a very low STS mortality risk score, and who is now like, what happened here? What do we do? What just happened? You're obligated, I think, at that point. If the patient have walked out of the hospital when they walked in the hospital, for all intents and purposes, I think it's a totally different situation than a patient who is in multi-organ system failure, is infected, is septic, is just looks horrible and is really old and wasn't doing well at home anyway. What are we doing that for?
Well, so how I'm looking at it, again, depends on your program, because you can compare patients from 20 years ago and patients now. At least the patients where I am at, 1 foot in the grave already. They're in heart failure, whether it be a valve, some type of function, coronary disease. And so they're not exactly the healthiest patient. And I've seen it, I would say 50-50. Just because they walk in and talk doesn't mean they're going to get the same outcome when they leave. And so really, for me, looking at that patient and saying, well, they came in just fine, so they should be a good candidate. That's not the case. Just because grandmother likes to sit at home in her chair and watch her grandkids from the chair, but because her age, that's her only limiting factor. I really just think you have to assess the patient as an individual and say, what is best for this patient? Now, the older you get, ECMO, not so much, because it will save you and it will get you over that hump. But again, at what cost? And I don't mean just from a financial cost. What does it cost you as the patient, as the family member? However, you got to look at the entire picture. What is your quality of life after this? Because we're only talking about survival. Survival truly means heartbeat, breathing, alive, pulse. It doesn't mean walking and talking with all your fingers and limbs, because we see that. You get these long-term patients, they get over the hump. The heart gets better, the lungs get better, but at what cost? They lose a finger or a leg. So they're able to sit in a wheelchair now, and so on and so forth. And so honestly, it depends on your patient population, but you truly need to look at your patient as an individual if you're going to make this decision.
Good points. Good point. Very good points. So in this study here, and I think this is going to be right up your alley, you can see that they reported, the question is, should we be mandating regional ECMO programs, because when you look back at all of the data, and I don't have all, I mean, I'm trying to cover so many different things about this, I can't get, each one of these topics is like a whole presentation unto itself, so I'm trying to sort of just, you know, cover as much as I can a little bit. The more ECMO you do, the better your outcomes are. I mean, every study says that. And so should we be mandating, and this is what the question is, ECMO centers regionally, you can put it in, but we're coming to get it, you're bringing it to us?
Well, that's easy to say that. It's like, you know, that you have affiliate hospitals. I get that. I work with you, you work with me. We're the heart failure. We trust you to put it in. We trust your judgment. Call us and we'll say, yeah, we'll take it. Put them on. I get that. But you and I both know at the end of the day, when it comes down to it, while I'm a clinician, somebody else is counting pennies.
Right. There's a financial incentive to keep the patient, and there's a financial incentive for you to take the patient.
So don't let those figures from earlier give you a misunderstanding that you put this patient on, you're going to get $138,000 in revenue, because that's not the case. In fact, you may lose money because your cost to put them on versus what you're going to get back even after you shipped them off may actually put you in the hole. So now you're like, we put them on, we saved them, they didn't die here, but it cost me $14,000 just to put them on, plus the staffing, plus the ICU fees. So now it cost me $45,000. And
you're only going to get those units for the days they were there, because the 138 is based on
total
a 26-day cycle.
Correct. So if now you got to say, well, we didn't have any negative effects. Well, financially you had a negative effect.
Right. Unless you're using a I don't want to keep laboring the point, a more economical system.
Correct.
Then you bring the big guns, we use something that's more affordable.
Correct.
So that it doesn't break the hospital's bank, and they feel they can provide this very important life-saving technology to their patients. So moving on from this, so one of their takeaway messages here, central message, was that mobile initiation of VV ECMO may be considered for select patients with ARDS. Outcomes were the same whether the ECMO was initiated at the central hospital or by the mobile team. So what they're arguing here is that the outcomes, whether we ship you the patient before the ECMO goes in and have you put it in, versus we put it in and then ship the patient, the outcomes were the same. So I think that's a good key point.
When you say that, basically you're looking at the right decision was made to put the patient on ECMO.
Yes.
And they were stable enough for transport. I do believe, you know, it's not taken away from either program, but if the patient is stable, transfer them. It's just from a safety perspective, you're sending somebody with a few lines and on a ventilator versus somebody with large cannulas in either femorally or depending on how you put them in the patient. Huge safety factor. So, you know,
cannulating femorally, of course, that's another part of the discussion that we're going to get into here pretty soon.
Right, but for
really
transport,
not a very good way to do this.
But what I'm saying is anybody who's part of that transport team, for the most part, can transport a patient. If that tube comes out, there's somebody there qualified to put it back in. But if one of those cannulas comes out, God forbid, and you stave it and stop everything and don't lose your circuit, who is qualified to put it back in? Only physicians.
Right.
So that's another.
Know-how.
The know-how,
just because you're a physician doesn't mean you know how to do that.
Correct, but that are quality trained. You know, the surgeon under, you know, a good background, everything, good environment, can put that in the OR or at their bedside if they're good, or under imaging. But going down 60 miles an hour down the road in the back of an ambulance or in a helicopter, that's another factor. So if you can transfer your patient, if it's understood that they're going to need ECMO and you want to transform, then transfer them sooner than later.
I think at the end of the day, Chris, if you're going to do it well. Okay?
Correct.
If you're going to do it, or if you can't do it well, don't do it at all, number one. Number two, I think that I don't really think a program that does fewer than 10 ECMOs a year should do any more than put it in and transfer the patient. I don't think you should keep them, because I just simply do not think the data does not support programs that do fewer than that, do 2 or 3 or 4 a year, have the experience to manage those patients well. So, you know, in some ways, I think you should have regional centers. In other ways, I question the wisdom, because 2 things. You don't have enough bed space, so you can only take so many of them. And I do believe you've been overwhelmed. We've been overwhelmed. We were taking your diversions, you know, a couple of years ago when we had that big flu epidemic, and we were in trouble. We were running out of places to put these people or resources to manage these things, which brings up another issue, which I think is going to be one of those provocative hot button topics that I like to do. So I'm going to try to get Chris riled up here a little bit, and we're going to have some fun with this. So, ELSO, who should watch the ECMO? Here is a hard fact that you have to accept. There are 4,200 and some odd perfusionists in the entirety of North America. That's a very small fraternity. There are 3.4 million nurses with 2.7 million unfilled nursing jobs, which you talk about a shortage. We have a shortage. That's a shortage. But even still, even with a shortage, they have 3.4 million versus 4,200. I think that, in my opinion, I think that ELSO is growing at a pace that will outpace our ability to provide the technical support that's needed, and I think we need to come up with some solutions. But let's do the slides, and I'll get you to make some comments. So ELSO says, anyone that has successfully completed an approved School of Nursing and achievement of a passing score of the state written exam by the Board of Nursing for that state, successful completion of an accredited School of Respiratory Therapy and have successfully completed the registry examination for advanced level practitioners and be recognized as a registered respiratory therapist, RRT, by the National Board of Respiratory Therapy. Say again? Oh, here, I'm sorry. Yeah, I got to be told to click the right button, guys. I'm sorry. Forgive me. Okay, so I just read that one to you, number 2. Number 3, successful completion of an accredited School of Perfusion and national certification through the ABCP. And 4, physicians trained in ECMO who have successfully completed institutional training requirements for the clinical specialist. Now, this is straight from ELSO. But this is the one that really got my attention. And I have to say, I am very proud of ELSO for this next statement. And let's read it. Other medical personnel, such as biomedical engineers or technicians who received specific ECMO training and have practiced as an ECMO specialist since the initiation of their programs and who have completed equivalent training in ECMO management as the other specialists, have successfully documented necessary skills as an ECMO specialist and who have been approved specifically as an ECMO specialist by the medical director. These people can be approved institutionally as an ECMO specialist under the grandfather principle. However, most important part of this whole paragraph, ELSO does not encourage or support the new training of individuals except as outlined in 1 through 4. I think that is a very important position for an organization that is recognized as the guideline, the guidelight of ECMO therapy as we know it today.
No, I agree. Absolutely right. I think it's a big factor. I'll just come out and say it. I prefer perfusion at the bedside. There's limiting factors. I work with plenty of nurses and other clinicians that I do find that are way more intelligent than me. They understand the hemodynamics, patient status.
Well, they're intelligent in what they do.
Right.
I wouldn't say they're more intelligent.
Well, but
you're a
for
pretty
them,
smart guy. I mean, but I say that too, and I don't mean to correct what you're saying. I think that it just has to do with what our experiences are. We know circuits, pressures. We can figure what's going on from a mechanical perspective because we understand the circuitry so well. It's what we do.
Right.
But they just have so much more experience in bedside pharmacology. They deal with more of the patient than we do.
Correct.
So I think that they in terms of managing the patient, not necessarily the ECMO itself, I think nurses are very well equipped, and I think they can be taught very well.
No, I do. I agree. Again, it's going to come back down to your center. I still think if a perfusionist needs to be there. If you're going to have a program
At the bedside.
Or when I say bedside, if you have 4 ECMO and you're a nursing program, perfusionist needs to be in the building, at least one. Also, it's going to come down to your program. You have a community center that does 3, 4, 10. Without a doubt, perfusion needs to be there. Your entire staff is not trained. I work in the medical center, and we see anything and everything all day, every day, around the clock. I get that. You want to train some of those nurses? Absolutely, especially those sharp ones or a respiratory therapist.
I disagree with that, but we can go round and round on that one, and we're going to.
The point being, I think you can train those, but at what level of training do you feel comfortable? That's the other question. Now, is this new? Like, it may be that you need to have a perfusionist for the first 24 hours. Then after that, or is this a long-term patient? Yeah, that's Mr. Smith. He's on VV ECMO. He's making slow progress. He's been trach now. He's slowly getting better. His lungs are getting better. Now John can watch him tonight. I'm available if you need me, but we know what his progress is going to be. But somebody who's hemodynamically unstable, you need to have that perfusionist at the bedside.
Especially if they're a VA ECMO patient.
Correct.
And they're having fluid shift problems, and you're having to constantly fluid resuscitate them or
Correct.
take fluid off or whatever it may be.
But it's also circuitry because, we just say these terms, VA, VV, but it's more complicated than that. You have a 400-pound patient, femorally cannulated, but has an open chest. Which do you want? You want to do the whole package? You want to be that nurse that watches all of that? Or do you want to be the nurse that monitors what you do and you let perfusion do what he does because this is a critical patient? You have to look at your entire program and your patient population.
And those are all, I think those are very, look, you're passionate about it. And I appreciate your passion. What do you tell the place, though, that only has 4 perfusionists? They do, let's say, 500 hearts a year.
Yeah.
They live in a place that, they see 10 ECMOs a year.
Yeah.
And they put an ECMO in, and one of them is on vacation. How are they going to manage that? Do you call for people to come in?
Well, there's plenty of ways around that. If you're doing 500 hearts a year, you're a known program. That's how I look at it. And so you got to ask yourself, we have 4 and we do this many hearts, you're going to have at least balloon pumps. You're going to have some type of device going in as your backup. If you do 10 ECMO a year, you need to have a game plan as a manager, whether an OR manager or a perfusion manager. Well, someone's going out of town. All right, hey, John in the city, we need you to pay attention and be available for us. Okay. Or, we don't necessarily put them at, these small programs don't do it at the bedside as much. It's usually a trauma or failure to wean for some reason. That's when I would have a sister program and say, hey, we got somebody we want to put on ECMO. Here's their information. Yeah, that's a good idea. Put them on, staff it 24, 48 hours until we can get there to get them off.
John's busy. I will tell you what, you like John. But I feel differently. I really do. I believe that perfusion should be intimately involved. Now, I'll give you some examples of why I feel this way. If you look at Children's Hospital right here in this city, nurses at the bedside are managing from start to finish, except for insertion, neonatal ECMO. They're neonatal up to 17 years old.
Right.
And then after that, they're considered adults, and it all goes to an only a perfusion run program. So, a 15-year-old is, I don't get it. I don't, let me ask you this. I'm going to challenge you a little bit on this. Other than those patients that you are having some real problems with hemodynamically, the patient's pressures are up and down, you're going, you're really in a lot of trouble. It's a VA ECMO patient. They're very volume sensitive. You're having a lot of chatter in the line. You're having to make decisions about adjusting the flow. And it's just a labor-intensive case, okay? And I'm not talking about the nurse at the bedside. I'm talking about the nurse ECMO specialist who is trained and has the experience from perfusion. other than those cases, we're talking about the routine VV ECMO run, which is not uncommon, or even a stable VA ECMO run, who the patient just needs a little bridge to get a little bit of cardiac function back. They're going to wean and they're very stable, and you have a very safe system. What do you feel can happen to that patient or that system that only a perfusionist could manage?
Well, really anything. So to go back to what you're saying, you said 15-year-old. So the adult population, generally it's an older population on these ECMO circuits. Can be 50, can be 30. But when you have these young person, under 18, 15, 12-year-old, usually what is it going to be? You'll get traumas, car accidents. I would say you'd get an occasional asthma, but majority of them are going to be your congenital patients.
Right.
Whether it be a lung problem or a cardiac problem. And so now you're just getting into a whole other ball game of, are they going to be transplanted or not? What is your destination therapy? And so because of that, it's going to take a skilled nurse and perfusionist together to do this, because these are volume sensitive. You know, if they're hypoplast, if they got some other cardiac congenital defect going on, it's going to take both of you together. But it's going to take a perfusionist, in my opinion, to run that, to troubleshoot that, because it's more than adult generic settings. Go on, come off. We have 3 or 4 liters of flow. Now you're looking at, well, we need a partial flow on this patient. We only need about 1 liter of flow because this is what they're supporting. And so it really does
take... And you got to worry about the anticoagulation then.
Correct.
Because your transit time is longer. And I know there's a lot of other factors.
Correct.
How much shunting is going on or not going on. And yeah, we do those. We inherently know that only because it's what we do all day. And I do agree with you. That's not something that's easily taught when it's not something you do every day.
Right.
It's
and
kind
so
of like
in that small hospital,
pumps.
that's why I'm saying, you say here at the Children's Hospital, Texas Children's, I don't know now, I don't know when the ratings come out, but they're #1 cardiac program in the country. At least they were last year. So you know that their staff, they know what they're doing all day, every day. But you take St. Mary's in the middle of nowhere, that's still a good cardiac program, but they don't see that every day. Perfusionists, because that's what they go to school for. People in the medical center here, that's what they do all day, every day. So anybody can be trained, but you got to look at what is the best for that patient,
Right.
What is the best for your program for the best possible
Experience
outcome.
and maintaining competencies.
Correct.
And that is not easy to do in any program. You're right. We have the competency and the experience because it is what we do every day. You're right. In a nurse ECMO specialist program where there is infrequent experience, they're never going to develop the same level of intimacy with the device that we have just by virtue of our use of it all of the
Correct.
time. However, if they are doing it a lot and it is what they do as a living and they are actually focused on it versus the nurse at the bedside managing it who only sees it once every 2 years, I do think there is a difference to that. And again, I don't want to belabor the point too much. In fact, we're going to go ahead and get off of it. I'm just going to say that and you can finish up with a final thought too, but I just feel that there is there's smoke, and it's not fire. It's not just fire, it's a raging inferno, and it has to do, that raging inferno is us not being able to take care of all of these patients that I think are coming. The CDC says we should be expecting another, within the next couple of years, another H1N1 type crisis with a new respiratory virus. And, you know, if we cannot provide the people, there needs to be a solution.
Right.
And if we don't try to find the solution now, then when the problem occurs, you know, foretold is forewarned. And how do we look ourselves in the mirror if we knew in advance we're not prepared for a real crisis? That's my last talking point on this matter.
No, I do agree with you, but sometimes necessity is the mother of invention. So you were saying let's plan for the future. That's what perfusion does. You know, we go in and set up for our case. We're constantly thinking of what's going to happen. But at the end of the day, you don't know what's going to happen. So you just need to see what you got and go from there. That is how I look at it. I do think nurses can watch at the bedside. I prefer perfusion at the bedside, but there is numerous factors. I mean, you can still have perfusion in-house. And what is your ratio? Oh, well, it's 4 to 1. Okay, so there can be 4 ECMO patients to 1 perfusionist. Nurses are taking care of it. I'm rounding on these patients. I'm available at a moment's notice. But at some point, you got to have the perfusionist there. You do.
I think we need to continue to stay involved. I would agree with that. But I think for the long term, sitting at the bedside 24/7 for 3 weeks, when the patient is stable after the first, once they become stable, I question the sensibility of resource utilization for those patients with us doing it versus us working hand in hand with nurses that we're making the decisions, we are involved with the protocols, we're teaching them what to do, and they're doing it for us at the bedside. To me, makes more sense, both from a resource utilization perspective and a cost perspective for hospitals to be able to continue to provide these services that are just getting too expensive. That's it. Okay, so we beat that one down. That was a good one. Whew! But I came out alive too. I'm happy about that. Well, we've seen that slide before. So classic indications: mechanical circulatory support, or even for VV. Bridge to recovery. We're going to put it in till you get better. Bridge to bridge, meaning we're going to put a short-term device in and then a longer-term device in and then do something with you. Bridge to transplantation, and I've got a real neat video at the end of this to discuss about that. And then destination therapy. You're getting a long-term device and you're going to live with this long-term device for the rest of your life until it fails and you pass. But now in the acute setting, bridge to whatever seems to be becoming reasonable, including putting it in, assessing the patient, and withdrawing after a few days if the patient is in refractory multi-organ system failure. And so I think that's going to be a change when we start making the decision to put the patient on ECMO, basically shoot first, ask questions later.
I don't agree with that. Actually, I think what happens now is, and I see it more and more because I get in trouble if I make that wrong decision. I'm not the one that says yes or no, let's put it in. In fact, I'm not the one manually putting in, but I'm the one that controls everything and knows how to put everything, assemble it together to put it in. But if I go into a room and they're actively CPR, you know this patient needs something, but I do say it. What is our end outcome?
Sometimes they need this.
That's the truth, but you got to ask yourself, you have it, bridge to bridge to transplant, bridge to whatever. That's not really the case. In these bigger programs, we know that. And so we get in trouble for that. You have a 20% outcome and you've had 60 ECMO this year. That's not good. You need to have a better patient population and say, this patient, they're not a candidate. If you're going to put this on somebody, you need to say, how are they going to come off of this? Are they going to get a transplant? Are they going to get another device, whether it be a VAD or something, or are they going to come off at all? Because if you're going to say, we're just trying to put this in this patient to get them until grandma gets here, that's not acceptable, and we won't do that. Makes us look bad, and that's a waste of resources.
Yes, that is. I agree with you 100%. But I don't necessarily think that's what this slide is saying. I think what this slide is saying is, let's get it in and then assess the viability of this patient, because sometimes I think it can be kind of gray at times.
Absolutely.
Is this patient
Especially with
viable
heart
or not?
failure.
And when you're sitting there doing this, what are we going to do? What are we going to do? And somebody has to make a decision right then and there. This patient's really not a good candidate for this. You're making a decision that is, I think, in the heat of the moment. And I think what they're advocating is put the patient on ECMO, get them stable, take a step back, assess the patient, and then make the decision as to their viability. But you have to be willing to withdraw. And that's the hard part.
Right, but you're going to have these centers that they look at your outcome for accreditation and gold standard and say, 20%? Really? Well, it was the heat of the moment, and this patient was dying, and it was either this or not at all. We put it in, and then we were like, okay, let's figure out our next game plan. Our physicians are excellent, so they're looking at this patient. With the exception of a few, somebody collapsing on the street or coming in through the ER, you know this patient. This patient was sitting in bed 2 today because for whatever reason they're here to get their coronaries fixed. Do they have any other comorbidities? Maybe. But you know enough about them to say, well, they look good and we thought we could fix them, so we're going to put this on them. But you got these other people that you think, well, they coded. Well, what's their problem? I don't know. That's not an acceptable answer. I mean, it's more than just resources. You're extending life whether they want it or not, and then you're going to say 5 minutes later, we're not going to do that. I wouldn't agree with that logic. I mean, especially in a community hospital, because everybody wants their patient to survive. Say if you're a great cardiac surgeon and you do 3 or 4 pump cases a week, and every so often you have one go wrong, whether it be stunning or whatever, or can't come off bypass, and you're going to say, oh, put them on ECMO. Unless you have an end outcome form that you're going to fix, that's not acceptable. You need to be thinking ahead. Like I told you earlier, if this patient is healthy enough for bypass, then you need to be thinking, can this patient survive ECMO? Mm-hmm. That's how I'd be looking at it, because the ECMO was there, and like you said earlier, it's here to stay. So you need to always think in your head, what is your end outcome?
Mm-hmm.
That's
how am I going to get this thing out?
How am I going to get it out?
Exactly. I agree with you 100% on that. So let's take a look at these slides. So what you see in the top left corner up here, okay, is your very traditional it's VVA. So you have an access in the femoral vein, you have an access in the right IJ, and you're returning here to the femoral artery. So there's a blow up of this portion down here. Now, the one over here, B, is a good example of it's also a VVA, but the opposite approach. You have an access here, and then you are returning to the femoral artery and to the right IJ. So you're trying to accomplish both VA and VV ECMO simultaneously. And here's a blow up here of the part down in the iliac, femoral iliac area. So that's kind of it, and I'm doing this to illustrate all of the various different potential cannulation techniques that can take place. Now, in this next one here, this is your typical VV ECMO with an Avalon catheter. So you have your access coming through here, and you have your return going back basically to the same place. And the advantage of this is that you don't have anything down here. And so you don't have the infection problems. You can sit the patient up. There's a lot of things you can do with this patient that is going to make their chance for recovery much, much better. I mean, I could take a patient who is completely just flat, and I can raise the bed up 30 degrees, 40 degrees, and watch their saturation come up when my VV ECMO isn't really providing everything that I want with an Avalon. And I see an improvement immediately just from the vent settings, because you're recruiting perfusion through other parts of the lung. When you're laying flat, you lose a lot of your anterior surface. It all ends up posterior.
So this is what I look at when you're talking about these cannulas in the Avalon. It's not that I don't have anything.
Hey, you want to use this?
No. It's not that I don't have anything against the cannula, but you're limited with that. Does it work?
Right here.
Absolutely. So here, but you have this right here.
Look, can we zoom in on this?
So what happens is you have your inflow and your outflow, but it's all right here. That's fantastic. You have, you're trying to decrease that risk for infection on the patient, gives you more mobility. But one of the downsides to this is, see how this is sitting just like this? When you twist it like this or in another direction, now you're going to have these problems. You're not going to drain properly. You're not going to return properly. And so that's one of the problems with the Avalon, is that it's positional.
It's a very finicky cannula.
Right, but if you have a generically speaking, if you have this one right here and you're inserted into a vessel, doesn't matter which direction that you have that pointed, it's going to drain everything in that area. And so, from my opinion and my experience, these do work, but I prefer single cannulas, or you can use a multi-stage cannula, but one cannula for one vessel. And that's how I look at that. That's
so you don't like dual lumen?
I don't like dual lumen.
So I'm going to that's great, because I've got cannulas coming up. So let's keep that here, because I've got another one right here I want to get your opinion about too. Because I have to tell you, I love this other one, but I'm concerned about it because this is pretty good size. This is pretty good size too. And where this has to go, I think that's going to be pretty tricky. I've seen a few people think they could stick these things in, and it's a lot more challenging than you think. Okay, so then let's go down here to the bottom right, And what you see here in the bottom right is a very typical VA ECMO, both in the femoral. So you have your access here from the femoral vein, and then you have your return here to the femoral artery, and here's a blow up of it right here. So that's these approaches, and there's more. I mean, this isn't all that can be done. There's actually more of them, believe it or not. So these are various different ways of doing femoral approaches. And these are some really interesting slides. So if you look over here, you can see that your venous drainage is inferior and your return here is superior. And I'll tell you what, I've done a couple of cases like this, and I actually used a femoral arterial return cannula as my access, a 22 French Opti, and then used the VFem, the longer venous, instead of for my access, for my return, and had them stick it all the way up into the atrium, and that worked really, really well.
They can work. At
But
the end
you're
of the
down
day,
here in the groin again.
correct.
And
You
that's
are.
a problem.
And it is a problem.
Big problem. And then this one over here, you can see that this is basically just a different type of cannula. Over here, you see the dual approach where you're taking femoral vein and then you're coming in through the right IJ into that. And this is essentially, oops, what happened? No, this is the same thing essentially here, but just with different cannulas. So you have the cannulas that you see here are the ones with the multi-stage, and this one is just a single port. And that's the difference in where it should be positioned. It shows you here from the spine and where your renal veins are, and kind of gives you a landmark of how far these things should be in. I thought it was at least an interesting slide to look at. Now, there's all kinds of problems that can occur with VA ECMO, especially. One of the biggest problems we have is the leg where the cannula is in becomes ischemic, and
Correct.
it's a huge problem. And this is how that seems to be addressed. This is a schematic of basically this, where you take this line, basically like a cardioplegia line almost, and you take it and use something that can tolerate high pressure, and then you side port it off and go into the artery distal to the insertion point of this cannula, and then you get flow down to your distal vessel. So when you do that, and if let's say the patient still has pulsatile flow, don't let the nurses get too freaked out when they can't get the Doppler pulse, because there is no pulse. It's going to be continuous flow
Correct.
at that
Yeah.
point in time. Right, exactly. But the toes pink up, and that's what matters. If the foot's
Perfusion.
warm,
It's warm.
it really helps. If the toes are warm, leave it alone. And then here's the Avalon. And were you able to get a real good close-up shot of that? Let me do. I'm going to take the stylet out so they can see it. So what you have is drainage port here and a series of drainage ports here. And then, let me rotate this around, and then your return is here. So this has to be down in the inferior vena cava. This is draining the superior vena cava. And right here in the middle, it's supposed to be positioned so that it's angled, and you can look at the slide, towards the tricuspid valve. And what Chris was showing you is that it's very easy for this to move, and a little bit of movement goes a long way. I've had that happen to me too. Now I'll tell you, I shouldn't tell you this story, but I'm going to tell you the story anyway. The thing is designed so that what they say is you put it into the right IJ like this, and you're supposed to be able to read. I don't know if you can see it. You can read the writing right there, okay? So I had to change the circuit out one day, and I decided I was going to change everything from the cannula from the points here. So I clamped it out, and I took everything off, and I grabbed the new circuit, and I got the line, and I went, oh shit, I forgot which one. I forgot which was in and which was out. So somebody pulled it up on their iPhone and showed it to me, and then I made the connections. Everything was fine. Patient did just great. So a patient left the hospital in a healthy condition, by the way. So that's this cannula here, but you're right. It has some. Now, I talked to somebody in Denver who said they reverse it, and so they don't even turn it towards the tricuspid valve, but he uses, now they're in Denver, so they're at altitude, but he uses 2 oxygenators in his circuit, and they're running like 7 and 8 liters of blood flow through this thing. Now this is a 31. There's a 33 and a 35. You got to have a pretty big one to get that.
Yeah,
much
but now look what you're having to do all that.
Right.
Or you can just put a regular cannula in and.
Well, I want to talk about your cannulation technique, but I want to also talk about this. You're familiar with this? Okay, so this is the now Levanova Protect Duo. And let me go here. And there's a radiograph, by the way, of the Avalon catheter. Before we get into this, let me tell you something else too about that Avalon catheter. That's very important. Is you have to have fluoro and you have to have echo to put it in, and I'll tell you why. If you run a wire in just using echo, and you see the wire in the IVC, you go, oh great, I'm in the IVC. You have no idea, unless you're using fluoro, if that thing looped and ended up down there. So you go advancing this thing.
Or perf something.
You start advancing this thing, and that thing is looped in the atrium, and you're putting this in, and it's just going to go right through that inferior right atrium and out.
Correct.
And you are toast at that point in time.
Patient.
So you
Yeah.
have to use fluoro. Cannot stress that enough. Don't let anybody tell you they can put an Avalon catheter in safely.
Anything,
with
yeah,
just
safely,
TEE.
correct.
You can do it, but wrong thing to do. So what do you think of the Protect Duo?
Actually, I think it's a fantastic cannula. The reason being is one of the things we run into is that RV failure. And so going from the RA to the PA, bypassing the RV, I think this is a phenomenal cannula.
Here, show the slide. Just let me show you the slide. There it is right there. So, yep, so it goes into the IJ, and then, but this is a 29, it's a 29 French.
Correct.
And that thing has to make it through, so you're using a pretty stiff wire, first of all.
Correct.
You've got to get that
Implant super
bend.
stiff.
So do you put a swan in first and then exchange the wire? Like, how do you float into the PA?
We still do it under imaging, same thing with the wire as well.
But do you switch your wire? Do you start off with a more flexible wire?
Correct. You get it there, and it's the same thing you like with your dilators. Once you get it in, then you come back over, you dilate, and you float it back over. But yeah, definitely phenomenal cannula.
It is, because one of the problems with the Avalon, this or the inferior vena or the femoral to right IJ approach is recirculation.
Correct.
Huge problem. So you're not benefiting as much, but this, I think it eliminates recirculation.
Well,
pretty close.
It will eliminate, but one of the benefits of this is because it's anticipating, and that's not why you're using it, but it's anticipating future problems. And also when you use this, so now this is coming out of the IJ, and you say, you know what, patient's having cardiac issues now. So now you can convert. So now you're draining both directions for your drainage. Now you put in an arterial cannula, and now you're able to go back on. Now you're on VA ECMO. Versus this, you can still do that with this, but now you're still worrying about that RV and everything else that's coming, and it's still positional.
So for RV failure, you really like this.
I do. Because that's another component. Again, as perfusion, that's what we say, okay, we got them on, but now what is our plan from here? And you start watching, no, lungs are getting better, but now RV's distended. Or
well, okay, what's the number one cause of RV failure?
ECMO.
VA.
Yeah, correct.
You fix the left side, you
Now you
support the left side, the
now
right
we're-
side can't handle
correct.
it.
Exactly
Happens all
right.
the time. So, what's the knock? What's the knock? There is a knock to this cannula. Do you know what the knock is?
I don't, from experience, so you have to put it in just right, or this, once you get a kink in any of this right here, then you got to get another one.
You're toast. Yeah.
Correct.
Okay, get another one. The knock on this is they will not sell it without their whole kit.
Correct.
And their oxygenator is both underpowered and has no heat exchanger.
I've used a couple of them before.
And basically, this cannula costs $18,000.
Correct.
That's the knock.
Correct. Well, but I don't put, so if this is going to save my RV, or if I'm thinking about that may be okay. Because we're typically, when we put these patients on, we change circuits. Unless we have to change for another issue, we're not changing cannulas. So once if the patient's on for 8 weeks, it's usually the same cannula, unless we have to do something about it. And so I don't discount this just because it costs. Generically, yes, but if you have another game plan for it, then absolutely.
I think it's an obscene amount of money, frankly.
Before
I think it's ridiculous.
healthcare is
I think
expensive.
It's ridiculous.
Well, healthcare is expensive.
Okay. So it goes like this,
Right.
drains from the right RA to the pulmonary artery.
Correct.
Just
Skips the
like
RV.
that.
Correct.
So you're just really eliminating all of this issue. Once you
No.
have it in place, not as much migration. I would think it's low pressure side.
Correct.
You don't. It's not like an Impella that's you always have to worry about it migrating and suctioning and all the other issues that come up. Which that's a great. I mean, they do have a nice right-sided Impella, but you get no benefit from oxygenation if you need it. This
Right.
has a lot more utility, I think. And the Impella's
does.
not cheap either. A right-sided
$20,000.
Impella, more than that. For
Right.
a right-sided Impella, but it's closer to 30.
Probably.
Yeah, so, 18 grand, that's a bargain. What am I complaining about? I don't know what I was complaining about.
Yeah, exactly.
You know what? I wonder if they'd give me one for one of these cups. Maybe they would. Okay, so here's a radiograph of the now Levanova / Tandem ProTech Duo going in, and on the right they've sort of taken that radiograph and overlaid the schematic to give you an idea. And in addition, so this is the ProTech Duo here, and what they're showing is biventricular support. So you're getting right-sided support, probably with an oxygenator interposed here, and you're getting an Impella coming in over here, yeah, and going down into the LV to give you left-sided support. So this is their version of biventricular
Correct.
support with pulmonary support on top of it. So how do we measure adequacy? And you know what? Can we do this? I think we're getting close. We've got a few things to discuss, but how about if we take a 5-minute break?
Okay.
Take a 5-minute
Sure.
break, use the restroom, get a glass of iced tea or something. My cup is empty, that's not good. So let's do that. Let's take a 5-minute break, and then we'll come back and finish up, and hopefully we'll get the phone lines open. I think I've got probably maybe 15 more minutes, and then we'll be ready to do that. I'll
Okay.
go a little faster.
Okay.
All right.
Imagine trying to drive a car looking only through the rear-view mirror. Critical decisions would be based on old and possibly inaccurate information. The same can be true of performing cardiopulmonary bypass without continuous inline blood gas monitoring. Terumo's CDI Blood Parameter Monitoring System 500 continuously delivers 11 critical blood parameters throughout the procedure. With other systems, periodic blood gas measurements provide static information. That is helpful, but limited. Continuous monitoring tells you what you need to know every step of the way, and that reduces risk. Studies show a direct correlation between blood gas management and reduced complication rates. The CDI System 500 has been earning the trust of cardiac hospitals and cardiovascular surgical teams for almost 20 years. It provides continuous monitoring of 11 of the most critical blood gas parameters, utilizing industry-leading technology. During cardiopulmonary bypass surgery, the shunt sensor can be placed in any arterial or venous shunt, or purge line with continuous flow. The shunt sensor uses optical fluorescence technology to measure PO2, PCO2, pH, and potassium in the blood. 4 microsensors and a thermistor well are in direct contact with the blood to accurately and rapidly measure the values. Light-emitting diodes direct light pulses toward the microsensors, which contain fluorescent dyes. The intensity of the fluorescent light from the microsensors will vary depending on the levels of PO2, PCO2, pH, and potassium in the blood. The photodetector measures and converts the light to numerical data, which is then displayed on the monitor. Blood values are always current with virtually no gaps. There is no need to make difficult judgments about when to draw a sample. Gas source or oxygenator failure can be rapidly detected. Continuous monitoring is especially beneficial during procedures on young or old patients, or with smaller perfusion circuits. Peer-reviewed clinical evidence supports the value of continuous blood gas monitoring. Contact your Terumo sales representative for a demonstration. or visit terumo-cvs.com.
And welcome back to the program. Hope you had a chance to go and use the restroom. I promise I will be looking at the YouTube chat once I get through this presentation. I appreciate all y'all's patience. So, measuring adequacy, cannulation options, anticoagulation. I want to hear about you and how you're doing that cannulation. I want to know what you really prefer, because you've been to our program before. You know what we're doing. We're doing the Avalon most of the time. Sometimes we do the dual cannula, but we're in the femoral, and I think we need to stay out of the femoral. But I want to get your opinion about that. Anticoagulation, unloading the LV. North-south phenomenon, also known as Harlequin syndrome, weaning, what patients are extubated and woken up and walking around on ECMO. So I think these are some things that are some good highlight points. So in VA, from my perspective in our program, what do I use to decide whether or not what we're doing is working? Well, can we wean the inotropes and pressors? Is the heart being unloaded? Are there signs of shock reversal? Is the acidosis resolving? Are end organs recovering? And are we perfusing the brain with oxygenated blood? So that's kind of where I kind of start with that. But there's three really big concerns when you do VA ECMO with peripheral cannulation. Now there's issues when you do VA ECMO even with central cannulation, but less so than when you do it with peripheral cannulation. And that has to do with LV distension and increased LV wall tension. LV and aortic root risk of thrombus is increased, and of course the north-south Harlequin syndrome that I've already that I mentioned. Here's a study that shows that the incidence and implications of LV distension during veno-arterial ECMO is very common. And you know what it does, it's as it says in the study, very seldomly recognized or increasingly recognized, but seldom reported in the literature. And not only is the heart distended, but when you talk about increasing the LV wall tension, so you have a sick heart that you're trying to recover, and now you are you're increasing the resistance to flow down the coronaries, and that creates, that's why the Impella really is, I think, if pure LV failure, probably a better choice, or central cannulation, probably better choice. But if you don't have a patient, if you have a patient who arrested and they don't have their chest open, I think it's going to be hard pressed to open their chest to put them on ECMO. But I'll talk to you more about that and find out what you guys are doing over there. But going on with these studies, this one here talks about that regardless of VA ECMO configuration, maintaining some degree of pulsatility is very, very, very important. If you don't, you get a lot of stagnation of blood in the LV and the aortic root, and that can create some very serious problems. And this goes on to also talk about LV wall tension, sort of what can you do? Can you put a atrial or transseptal catheter in, which is what tandem heart used to do? Well, that gets the LA, but it doesn't necessarily, and it may reduce your pulmonary edema, but it doesn't do anything for your LV unless you have mitral regurgitation. And this kind of study goes on to talk about decompression and distension. It talks about afterload, but it also goes on to say, if you look right here, I probably should have highlighted this. So look in this area right here. It talks about insertion of an Impella device is another effective, albeit expensive means of decompressing the LV when you are using peripheral cannulation for VA ECMO. I think that it is underappreciated by a lot of people. But please don't be this guy. Never, never, ever use VA ECMO with peripheral cannulation, especially the femoral artery, for pure pulmonary failure when there is no LV dysfunction, or especially if you have a hyperdynamic heart on a young patient. So let's do this. Let's stop at that slide. You saw what my thoughts were about adequacy, measuring adequacy, and my concerns about these various things. Care to elaborate?
Well, so I do agree with you for the most part. I'm always going to say you need to look at your whole patient before. You know, you can't just say we do this because of this. Protocols or guidelines, they're not absolute. But one thing that I do agree with you on that. However, I do prefer femoral cannulation versus the IJ. Also with, or really anything, especially with the VA, that's fine. Some of the things that we do is that you do run into is that for us, we do practice this, and it's a good practice. You get called to the bedside, patient's been crapping out on the ventilator, they're maxed out on the settings, they need VV ECMO. But upon insertion, patient decompensates for whatever reason. So whether it be hypotension, fibrillation, arrhythmia, or whatever, so then we do go to VA ECMO. Because what's the point of putting in the VV for the lungs if the heart's not doing what it's supposed to upon that? So what we do practice, and now we do run into problems later on occasion, is you put the VA in, then you need to convert to VV. So that's why I do prefer VAV ECMO.
VAV.
Correct.
Okay, gotcha.
And so that's when some of these cannulas come into play, because now, whether I like this cannula or not, if you're on, you can use that to drain with, and now all you need to do is put arterial cannula in. And so now you're providing both pulmonary support and cardiac support.
And you can split your return.
Correct.
Right. So you can have one return going back to this, the Avalon.
Correct.
And one going to the femoral artery,
Correct.
for example.
Now,
but for VV, do you really, I mean, okay, so just tell me what do you prefer for VV, pure VV? Patient's got a great heart, there's no problems. It's just VV, it's a lung problem. They were firefighter and they have smoke inhalation, and now they have ARDS secondary to that irritation. How do you prefer to cannulate them?
Well, again, it does come back down to preference, but if it's mine and I'm making the decision, I still prefer femoral cannulation.
Really?
Yes, I prefer femoral cannulation.
What about the infection risk, though? I mean, that's such a big thing.
Okay,
And
you
can't
pulled
set
it up. You said a firefighter. What infection do you think you're worried about? Their airway's already damaged. We're throwing the book at them for antibiotics. I mean, to limit yourself because of access purely on infection, I don't think is that big of an issue. I mean, because what are you going to prefer if the chest is open? You still want to leave the chest open and go femoral? I mean, you're at risk for everything else.
Tunnel them. You can tunnel the cannulas
Correct.
for
So-
central cannulation and close the chest.
No, I just prefer femoral cannulation. It's better all around for mobility. Granted, if you got to look at your end game again, your mobility for what? To move the patient, position them in bed, or to get them up and walk them around?
How much will you sit a patient up if they have traditional fem-fem cannulas?
I don't know what it comes down to the degree of the bed, but we'll go them up. But we look at the patient access, you know, and what we end up doing is we elevate them, put wedges in there, but we're not going to impede our flow just to sit them up in bed.
Okay.
So again, going back to what I'm saying, I do agree with femoral versus the IJ.
So we just, yeah, okay. So, yeah, I don't know. That's a really good, and you do a lot of cases. I mean, I think I'm going to reconsider how I feel. I don't like it because I feel like I really do like to set the patients up. I really do feel that you have way less infection risk. I understand they're on a lot of antibiotics, but I just feel like the femorals are, and then of course if it's VA, I'm really concerned about this north-south phenomenon. I've seen it happen. That thing the slide I had, don't be this guy, is because I got stuck in a case similar to that. In fact, let me tell you about this case. I'll tell you all about this case too. This is probably the worst case I have ever had in 40 years. We were called for a patient that needed to go on VA ECMO. Clearly, I'm not going to say where. And they had already put the cannulas in. This was a 22-year-old who was a fairly robust individual. Now, he had some other issues going on. He had some viruses. He had TB. He had other issues. But he was still pretty healthy 22-year-old and undersized both the femoral venous and the femoral arterial, but they were already in, and insisted that this is what we were going to use. We put the patient on VA ECMO, and they put a femoral arterial pressure line in the contralateral femoral artery and kept drawing the gases from there, despite me telling them, you got to draw it from the right wrist. You need to draw it from the right wrist. You need to draw it from the right wrist. 2 days later, when the patient was certainly not improving, in fact, getting neurologically worse, they finally did a right radial saturation, and it was
40.
Well, it was 48.
Yeah.
Yeah, right.
So right, no, I agree on that. You need to be
horrible.
aware of that. You need to be aware of that. But so there's different ways you can look at it. Basically, you just say, hey, either slow the contractility down. I mean, if you're resting,
Give them a big time beta blocker. Put some Hezbollah on.
exactly. Short term beta blocker.
Something that's short
Slow it
acting.
down because basically you're competing with the ECMO at that point.
Right.
We're overworking the heart. Or you do put it in an IJ. So now if you're fem-fem, now you put it in an IJ. So you got to ask yourself, well, how do I fix this problem? I'm oxygenating the patient, but on the lower extremities is what I'm oxygenating. I want to fix up here. So you collect what's draining up top. So you reduce the amount that's going to the top. Versus,
decompress the heart.
You
by
either
emptying it better. VV ECMO.
correct.
Right.
So you just have to. The same thing can be done, but it's like, how do you want to fix it? Do I want to slow the heart down to fix it? Do I want to drain the heart better to fix it, or do I want
both.
to? But it goes back to infection. Okay, cardiac wise, how's he doing? Fantastic. He's a young, healthy patient. Great. Bite the bullet for the infection. Not saying you're going to get an infection. Now switch your cannulation technique. Now go to VV.
Yeah, I'm going to reconsider that, what you're telling me. So here's a schematic showing basically the Harlequin syndrome, the north-south or dual circulation phenomenon that occurs in various different conditions. And you can take a look at that and go review it, later at your leisure. Here is another example of this very real problem that is a real problem that we have to be highly vigilant of when we're doing VA ECMO and think about it. And I want to show you these two quick videos. These are really good videos. Oh, do we have sound?
Yeah.
Oh, you have it, yeah.
But I don't hear it.
VA ECMO is often performed using peripherally placed cannulas, typically placed in the femoral vessels. This animation shows arterial ECMO access in the femoral artery. With extreme cardiac dysfunction on ECMO support, if the heart is not beating and the aortic valve is not opening, the blood being pumped through this cannula provides 100% of the patient's blood flow.
But remember, that's going to be
In
a
this
dilated
scenario,
heart
there's
now.
no mixing of the two circulations since no circulatory support is being provided by the native heart. Upon return of cardiac function, when the heart starts to beat and the aortic valve begins to open, the situation becomes quite unique. Because the peripherally placed ECMO cannula is pumping blood in a direction that is retrograde to the native blood flow, the two circulations merge or mix together in a location somewhere between the aortic valve and the arterial cannula. As left ventricular function is restored and contractility increases, the mixing cloud may shift distally in the aorta towards the arterial cannula. The same shift can occur if the ECMO blood flow is decreased. Conversely, as ECMO blood flow is increased, or as left ventricular function decreases, the mixing cloud may shift more proximally in the aorta. Let's take a closer look at this phenomena. Once again, with severe cardiac dysfunction, if the aortic valve is not opening, blood mixing does not occur in the aorta. However, as the heart begins to eject, blood traversing the aortic valve begins to mix with blood traveling retrograde from the arterial cannula. In the scenario shown in this animation, blood sampled at various sites throughout the body would have a similar composition. The exception may be the coronary arteries due to their proximal takeoff from the ascending aorta. As the heart contracts more and more forcefully, or as ECMO flows decrease, the location of the mixing cloud can migrate more distally in the aorta. In the scenario illustrated here, consider the impact of the circulatory pattern on cerebral perfusion. The brachiocephalic artery is perfused by blood from the left ventricle, which may be poorly oxygenated. However, the distal arch vessels are perfused by a mixture of blood being pumped from the left ventricle and blood pumped from the ECMO circuit. Blood sampled from the right radial artery, for example, may have a composition that is markedly different from blood sampled at the ECMO arterial line. As the heart continues to recover and contractility increases, or as ECMO flows decrease further, the mixing cloud can continue to shift distally. Again, consider the impact of these scenarios on regional perfusion and on differences in blood sampled from various sites in the body versus blood sampled from the ECMO arterial line. In addition to understanding where this mixing occurs, the ECMO specialist should understand the significance of mechanical ventilation in these scenarios. Blood being ejected from the left ventricle generally perfuses the coronary arteries and may provide cerebral perfusion. So care should be taken to adequately oxygenate blood traversing the aortic valve if the lungs are capable.
Exactly. So you got to keep that in mind. In that scenario, you have to, in this case, assume that the lungs are not working well. So peripheral cannulation VA ECMO, if you have really good lungs and your heart is strong enough to produce a pulse, albeit unable to handle the load all on its own, then I think you're in a pretty decent situation that it's going to stay relatively empty. Your wall tension won't be too high. The lungs are working. You won't have this mixing cloud phenomenon. But, if you don't really know what you're doing and you think, oh, the patient's on ECMO, we can just turn the ventilator off now. Well, no, you better not do that.
Correct.
That would be a very bad idea. So keep it in mind. You got to be able to think through this. And I think that's to your point earlier that, we watch the ECMOs because we just know this.
It's not about just being on there writing numbers down.
Right.
We're assessing the patient. We're looking at things. We're troubleshooting things
Right.
that we're trained to look
And
for.
anticipating these as potential
Correct.
problems that can occur. So I mean, I think that's a very fair point. So let me show you this other quick video. Mayo did a really nice job on these. Dose circulation with veno-arterial ECMO with central cannulation. I'm not going to let it play very long.
VA ECMO is often performed
Just
using centrally
for a short
placed
period of
cannulas,
time.
meaning that the cannulas are placed in
And
the
I'll-
great vessels in close proximity to the heart. This animation shows highly oxygenated blood from the ECMO circuit being returned to the patient through an arterial cannula placed in the patient's ascending aorta. With extreme cardiac dysfunction on ECMO support, if the heart is not beating and the aortic valve is not opening, blood being pumped through this cannula provides 100% of the patient's blood flow. In this scenario, there's no mixing of the two circulations since no circulatory support is being provided by the native heart. However, as the heart recovers and begins to beat, the aortic valve opens and blood flow from the native circulation now mixes with blood exiting the centrally placed arterial cannula. The composition of the blood distal to that mixing cloud will depend on the relative outputs of each of the two circulatory systems.
So I don't want to keep it going because it basically does the same exact thing. But the difference is in central cannulation, you can see that your mixing cloud won't be as bad. It'll be mixed, truly mixed. But the coronaries in this situation can end up, you can end up very, very ischemic.
Correct.
Because of this. Even with central cannulation, it is not a good idea to be on pure VA ECMO when you do not have adequate pulmonary function.
Correct.
Even with central cannulation, it could be a problem with the coronaries, and then you end up with an MI.
Right.
So let's explore adequacy of VV ECMO. Well, are you able to reduce the vent settings to lung protection levels? That's my number one thing. And maintain at those settings an arterial SaO2 of at least 90%. And can you achieve a PCO2 of 50 or less? What do you think?
For the most part, I do agree with those. We follow ELSO guidelines. On top of that, we still go with the ARDSNet as well, ARDSNet trial as well with that. But I do have to say this. I've already said it once. I'll say it again. You really have to assess your patient because to follow a number, something could be wrong somewhere. Assess your patient. But for the most part, I see these. But one thing that we also look at is your lactate that you don't have included in here. And so,
Well, I had that in the VA.
correct.
Not so much in the VV, but we do look at it.
But
yes.
the point being is, a lot of times is your pH within normal reason. Are you compensating? Yes. Is your lactate climbing? No. Then we have a little wiggle room. Your CO2's in the 50s, maybe 60s, because again, for your pulmonary patient, what kind of pulmonary patient is this? Is this a young, healthy person that had pneumonia, H1N1, or is this 65-year-old grandfather that smoked for 30 years and quit, and now his CO2 is normally in the 50s or 60s? Is this smoke inhalation? You know, what are you looking at exactly? You need to go more in depth into your patient population.
So what's CO2? Well, like, what's your on a
I'm okay if my
regular-
pH is normal and my PO2 is relatively okay. Obviously, we want higher the better, you know, to help improve because we want to rest the lungs. But if my CO2 is 55, 60, but my pH is corrected for the most part and my lactate is not climbing, I'm okay with that patient. Okay. Also, the things that you didn't take into consideration here is what is my temperature? What's going on with the patient? So
I didn't even discuss that. You
so
know that?
there's different aspects to what is my metabolic demand of this patient.
Cool your patients routinely.
It depends on the patient population and what is wrong with the patient. Is this a CPR in progress? Put them on there. We do a cooling protocol, hypothermic
Right,
protocol.
hypothermia protocol
We do
in those
those.
cases.
So, but we don't just say cool them because of this incident. It's like, well, are they responding after everything is said and done? Are they, fighting, combative in bed? John, cut it out. He's awake. He's alert. Sort of. He's responding to your commands. There's no need to cool that patient. But if you suspect anything, cool your patient, usually like a 24-hour period, then slowly warm them up a degree. We have a protocol that we follow. So again, you really can't just generically throw settings on there. You got to say these are protocols, these are guidelines, but those are good guidelines, but assess your patient.
Okay, fair enough. That's a good point. Anticoagulation. I like to see an initial bolus of 5,000. My goal is the APTT at 1.5 baseline. I do not like to do ACTs, except for an initial one to see that I had some reaction to the heparin that was given the initial bolus. I usually like to see the APTT done every 4 hours, and I generally start out at about 7.5 units per kilogram per hour as an initial dose drip. And but again, I don't like the ACT low range because I just think that it's widely, in my view, inaccurate, and an APTT I feel is going to give me more valuable information.
Correct. I agree. So what you got to look at here, one, for your anticoagulation is your ACT gives you a direction that you're going. So all of us generally, if we're not on any drugs or aspirin or anything like that, around 100, 120, maybe 130, you're okay with that. But this patient right here, I just want to see, when I initiate, I prefer to see 180 and above.
Okay.
You got 180 and above, we're golden with that because of that bolus. But then you need to titrate. However, what I don't agree with is you're saying do this because of this with no protocol, no backing behind that. I think you should have an algorithm for these, especially for these VV patients, because pulmonary-wise, majority of these patients that I see, they don't have other comorbidities. You may be a little overweight or you may have been a smoker, but cardiac-wise, you're fine. From a heme path aspect, they're fine. So you need to have a more of an algorithm for these patients. To say I like 7.5 units per kilo per hour is generic, because I'm, over 100 kilos versus 68 kilo patient. So you need to implement a protocol like you have with anything else. You have your, coronary syndrome patients that come in. You have your VAD patients that come in. They've designed and built algorithms that says, for this patient population, it's based on weight protocol versus just a generic initiation. So you need to say, for this patient, you need to give 8,000 units of heparin as your bolus. Then we start them, instead of, because you're going to have a sliding scale anyway, you need to say, okay, this patient, do the calculation, we start somewhere around 12 units of heparin an hour, and then we titrate 2 to 4 based on this sliding scale protocol. And then by that time, it's much more titrated to that patient population versus generic settings. Because if you do this, what do you think is going to happen? If you are an ECMO patient and then you have a 40 kilo ECMO patient, what are the odds that that program right there that you're using is going to get you therapeutic at the same rate as the 60 kilo patient? Not
Me?
Yeah.
I mean, depends.
No, you're not, because
the 60 kilo patient could be AT3 deficient, and I don't know.
But
that.
see, we're assuming.
I'm going to check the ACT
But what are the
to
odds?
make sure
No.
I got therapeutic, and if I didn't, I'm going to give them some more. But if
Right.
I've got a horse come in that's a 300-pounder, well, okay, this is sort of a kind of a guideline kind of thing, like you said. But no, if a 300-pounder comes in, I'm probably going to give them a little more heparin than 5,000.
Right.
So this is not to say this
so
is
design
all
this
I would
on a
do.
weight-based
This is
protocol versus generic
So you're
settings.
saying your initial bolus weight-based
Your
as
initial,
well.
because what happens is you can say give 10,000 to everybody. Again, these are
The 40
VV
kilo,
patients.
though, is going to blow them out the water, and the 100.
We're assuming that everything else is
kilos.
correct, and so
Okay.
now you're saying, you know what, just give everybody 10,000. Great. So now what do? Yeah, everybody's ACT is going to be over 200. Great. We don't have any other coagulopathies, no platelet dysfunction or anything. Great. So now what happens? Now you check, and you just wait for it to come down now. Now you're going in a negative direction because once you've checked something, it's still going further
right.
than that. So now you're saying, oh, we did ACT, but we do PTT. Well, you don't do PTT in 5 minutes, and you say, you give this, and then we check it in 6 hours or 8 hours. So now what happens is in that 6 or 8 hour window that you're waiting for the next one, now your range is 55. Okay, now you're at 55. I'm comfortable with that, but we still don't have anything on board. We still have that initial bolus. So now you're saying, well, let's go to the next one. In 6 hours, now you check the next one, now they're 29. So now you're troubleshooting. Now, do I give more? Do I give less? When do I start my therapeutic
Well, no, if
dose?
it's 29, I'm
maintenance?
going to give more.
Yeah,
At
but
least I'm going to.
But you had to wait 6 hours to find that out.
That's true, which means it's probably even lower than.
So
or
now
that's
this
normal.
patient that's pulmonary, dependent, clearly because you put them on VV ECMO, now there's that chance that circuit clots off, and you got to change that out.
Okay. Very good. Good points. Weaning. Let's talk about that real quick. There are weaning tests. This is a weaning protocol for VV ECMO. This is how they recommend do it, decreasing your sweep, gas flow to 0, adjust your FiO2 as you increase the ventilator on that, and make sure that you can maintain a PaO2 or saturation of 90% with the FiO2 on the ventilator at 60%, and your peak pressures at less than 30 centimeters of water pressure. And take a look and make sure you don't have any right heart failure with an echo, and do this for at least 1 to 2 hours, up to 12 hours before you decide that this patient can go ahead and wean off of VV ECMO.
We usually do follow something similar to this right here. What we look at is definitely the peak pressures for sure. And basically, we want VV, when you really look at it generically, you want a shunt going on. So how do you know this patient's ready to come off? Well, basically, you're going to turn your machine off, everything but the flow.
Right, don't turn the flow off.
Correct.
So many people on a VV ECMO, I have seen them turning the flow. Why are you turning the flow down? Just disconnect the gas line.
I won't say disconnect, but turn it off. Yeah, go to room air.
Turn your FiO2
and then
off.
now it's essentially a shunt. You got
21%.
blood coming out of the body, going through your whole circuit, going back to the patient, and
Receiving no oxygen.
receiving no support from us.
Right.
And so now you're saying, okay, this is good. We usually go 24 hours. The problems that we're running into is because something's not scheduled, 24 turns into 36 because of this, because of that. Now you're at risk for a stroke. Because you're still staying heparinized because you got this blood leaving the body, coming back and being filtered. So that's something you have to look at. But these generically, I'm not saying you have to do one or the other. It depends on what your patient needs and what your program is comfortable with. But those are the settings you want to look at. Because basically what you got to tell yourself is, all right, now the ECMO circuit is a shunt. It's working for the patient. We're not using it anymore. Can I take it out? Well, sure, you can take it out, but how is the patient's oxygenation? But what the real problem is, so now you take it out, is what backup do I have? So now if you go to these settings, you're saying I'm 60%, so now I can go back up. I can increase PEEP. I can do these things.
No, you have to be at a, see, I think what this is saying, and how we feel, is that you have to have upward mobility.
No, that's what I agree. That's what I'm saying.
At 60% with with PEEP, maybe only at 2.5 or 2 or 5, maybe no more than 5 of PEEP. If you're still on 15, if you need 15 of PEEP or 10 of PEEP and 15 of PEEP, and you're barely getting 60 PO2 off of it, off the lungs, with otherwise maximum.
I see what you're saying. I meant 60% on your ventilator.
Right. You've got to get that right. If your FiO2 is less than 60, you have it at 40.
Yeah.
And your peak pressures are running about 24, 25, and you have 2 of PEEP, and then you're basically, the ECMO is not giving any oxygenation support. I think that patient's ready.
I'll give you that. I agree. But basically what I'm saying is, once you decide that you're not using it and you're not relying on the ECMO device, you got to ask yourself, what can I do if they go backwards in a hurry? And so if you're at 80% FiO2 with a PO2 of 60, it's like
you have no upward mobility.
Nothing. You're not going to do much more. But if
your backup plan has to be the vent in the lungs.
Correct.
The lungs have to have recovered enough.
Correct.
That you can recruit them with a little more ventilatory support than where you're at.
Correct.
So I don't have a problem with seeing 40 to 50 and maybe even 40 to 60. But if you have to go back to 100% on the vent, that's going to be that's very bad for the lungs.
Correct.
To begin with, and then if you're still on, like I said, if you're on 10 of PEEP, or let's say you're even on 5 of PEEP, but you're at 80% and you're barely getting 60, no, I don't think that patient's ready. You got to think about it. You do have
Correct.
to really
Correct.
think about it is easier to leave it in another day than it is to take it out. Well, it's not easier, but the result is going to be a lot better if you just wait another 24
Correct.
hours. I think I agree with you on that completely. Okay, weaning from VA. That was kind of weird.
Was that a transition?
Oh, that was mine. That was on mine. I forgot. I clapped. Oh, that was my slide. Sorry about that. So I had a clapping sound. So, okay, weaning VA ECMO is much more complex. Please don't be this guy. The red arrow is pointing at him. Don't turn the FiO2 of the ECMO circuit down when you're weaning off of VA ECMO.
So we don't, period, wean FiO2. You're
Right.
100% the whole time.
100%, exactly.
It really, your slide that you had on there earlier and your videos go back to that. That gives you a good example. So, especially if you're femoral cannulation, your positive pressure coming up, and you got that mixing cloud going on. Doesn't matter where it's at. So what you got to ask yourself is, why are you weaning FiO2? Pulmonary, whether they're doing it fine on their own or not, you don't want to give them bad oxygenated blood. You don't want to give them
Right,
deoxygenated
you're
blood.
creating a VA shunt in
Yeah,
the
great.
arterial
Their heart is
system.
functioning
But
now.
I've seen somebody do it.
Yeah, it's essentially
Why I
like
bring
you're
it up.
exactly. You're causing the Harlequin syndrome.
Yes.
It's on your end this
Causing
time.
it, this time. Yeah, and you're worse than that. You're just giving them desaturated blood everywhere.
Exactly. So because you don't know where that mixing is occurring on the patient.
No, absolutely not. But if my kidneys want a PO2 of 100, I don't want a PO2 or 90. I don't want a PO2 of 40 in my kidneys.
Exactly.
If
You
don't
shouldn't
mind.
wean FiO2 on a VA
Yeah.
ECMO.
You got to make sure that you're anticoagulated though, because how you wean off VA ECMO is you have to turn your flow down. Now we like to do about 500 cc's per hour plus or minus, and evaluate each change, fine tune the volume and the drips, take a look at an echo, and of course I like to consider CRRT for fluid volume control. I think that CRRT is
I
a
agree.
really nice way to control if the patient gets a little fluid overloaded, the heart looks a little stuffed. You can really make the heart a lot happier, I think, and make them beat a lot better if they've been a VA ECMO by having a more empty heart.
Correct. No, I agree. Most of those things are the same thing. Wean your patient down. Now, we do not prefer to go below 2 liters for clotting purposes, even if you're properly anticoagulated. And I've seen other programs that I've been at, they say, oh, go down to a liter and stay at a liter. We want to see what their support is. We can do a check if you want to do that. We can say, all right, go down to 1. Let's look at their map, look at their contractility, do an echo, if you will, and do all these things. And, the patient tolerated it, great. We don't know what 30 minutes later comes, but we as a whole, we like to keep it at 2 liters of flow always. And the same thing, your drips are going to be equivalent to your ventilation. Your drips are at a minimum or off. Your flows are down to 2 liters. Contractility is good. Echo is good. Your chances of coming off and weaning off this are good.
Good, okay. So I agree with that 100%, and I think I agree with you on not going below 2 liters, because if you do, one, I think that you have to really anticoagulate the patient way more than you should have to. At 2 liters, I feel pretty safe still with a PTT or an ACT of in the 180 range. I'm still pretty comfortable. But I think at 1 liter, I start to worry about especially have to go back up, what effect that's going to have. So extubating patients on ECMO. I've heard of this. I hear people say it all the time. I want to show you a quick video here of this patient who is on VV ECMO, who is getting up, and you can see her moving over to the chair. Let's open the phone lines too. And she's going to walk down the hall. They're exercising her. I'm not going to let the video run.
Good job.
I just wanted to show you. She is on VV ECMO, and she's going to push that cart down the hallway and get exercised. And look, there's a CDI 500. I just saw it this morning. Okay, so I think that's long enough to give you an idea. All right, let's talk about waking patients up on VV ECMO, okay? Because I hear some of these intensivists and pulmonologists, and they see videos like this, or they talk about Dr. Oz's program up at Columbia, where they had all these patients on VV ECMO up walking around. That patient that you just saw of that video, she was a lung transplant candidate who was decompensating a little too much, so they put her on VV ECMO and then expedited her up, moved her up the list to get a lung, okay? Otherwise, she was her problem is chronic, not acute. She's not infected. She doesn't have SIRS. She has a pulmonary problem. It's not ARDS that's secondary to either a flu or pneumonia or whatever other issue it was. When I look at our patients, our typical ECMO patient in the community-based hospitals that I'm dealing with, and yeah, you got the phone lines open, thanks. If somebody wants to call and ask a question, we're ready for you. And we're doing good on time. This has been a really fun way to do this. But they're sick, man. They're sick. Their white counts are through the roof. They're febrile. They've got other issues. They got some renal insufficiency now going on. They're fluid imbalanced. They're messes. I couldn't imagine waking some of these patients. I would imagine they would feel like hell and not do real well awake in that particular condition.
Again, it goes back to your patient population, but she's a good example. But these patients, I mean, half the problems that we see from these patients, just overall, you know, you got infection. Well, where'd your infection come from? Well, I laid in bed and they didn't rotate the patient. Was the patient awake? No, a patient was asleep, you know, sedated, laid in bed. Now he has a decubitus, got infected.
Yeah.
Now we have a problem. Okay, same thing. All these other issues, what you want to really look at, I think she's a good example. Not everybody needs to do that, but if you're going to be a transplant patient or and usually a VV patient, you need that conditioning. You need to be able to stand up, move around, and all.
For a transplant, when you're getting ready for surgery,
Right.
But I'm trying to now move that away from that patient who I agree with you, it can do that. But what about the patient that I described that is febrile, is septic, has SIRS, has ARDS, acute ARDS?
Why would you want to wake them up?
Right. So, you know, but at what point do you, in other words, as they improve, do you, when you start seeing improvement, wake them up and possibly even extubate them on that patient scenario population and then eventually wean the ECMO down? Would you do that? Or if those patients that I just described...
The extubation, that's a sensitive area. That's a great area because you really have to look...
Because she was extubated.
She was, but you got to say, well, why am I extubating the patient? But to wake them up, no, because you want to assess neurologically. Remember, these patients are heparinized or some sort of anticoagulation going on. So you want to say, I need to wake them up and see how they are neurologically. They're listed, but they've been asleep the whole time. Okay, we'll turn off sedation. Now they're not waking up, but you got a heart or a lung on the way. Well, now they're not awake. They don't need that transplant per se. They're neurologically not there. So there's reasons to wake them up, absolutely. You want to see can they follow commands, but hers, I would agree, like you need that mobility, you need that to move up on the list. Well, she's dependent on ECMO. How dependent on ECMO is she? Well, she can't breathe with that, okay, but can she do everything else? Yeah, absolutely, watch, we'll walk her. Clearly she needs the transplant. Because I've had a patient awake, alert, he couldn't tolerate anything. He couldn't even sit up. PT comes in, he was alert, extubated, he was on the Avalon just like that. But you say, okay, we're going to put you on the transplant list. Because essentially your lung, the VV ECMO is your new set of lungs. How do you tolerate that? Okay, stand up, can't do it. You're so deconditioned that your VV is the only thing keeping you alive, you're not going to get a transplant.
Yeah, because you're not going to be able to recover and do the PT needed after the transplant.
Correct. So why are we going to waste an organ on you?
Yeah, yeah. That's scary. That's some scary stuff, dude.
Yeah.
That's scary stuff. Yeah. Well, any final thoughts?
No.
I think we're look at this, right on time, 1955. If anybody's going to call now. Look, people are checking. Oh, I just saw it go from 20 to 16. I guess they figured the program was going to be over. Nobody wants to call. But we have not got one thumbs down. We got 13 thumbs up. So Chris got 13 thumbs up. And if anybody gives us a thumbs down, Magic and Roger are going to bring the Polish and Mexican mafia to your home. So no thumbs downs. And I want to thank everybody for joining us tonight. The program, of course, will be on YouTube, and they can go back and re-review it if they want to. And just thank you very much. Appreciate it. Thank you, Chris.
Thank you.
Good conversation. Oh, wait. We are just getting TEG 6 machines. How about, we still on?
Yeah.
Oh, good. We are, okay, Meerkat Supreme. Hey, Meerkat. We are just getting TEG 6 machines. How about using TEG for anticoagulation monitoring on ECMO instead of ACT?
No, I agree. I mean, if you have that ability to do that and time and everything like that, I still think your ACT is going to be your go-to for your initial, just to see that you're anticoagulant, you're moving in that right direction. But a TEG is perfect because now you're being specific. You're not going to say, yes, we're bleeding. You're going to say, everything's working and this is what we're going to need to correct it or not correct it. I think that would be a good idea. It's just not every hospital has that ability, you know, tag platelet mapping or whatever.
Meerkat, can you, oh, hey, Andrew. Hey, Andrew from St. John's. Andrew, you're getting a cup, okay? Cup's coming your way. And thank you. Excellent question. I hope that that got answered for you. Let's see. Did we answer your question? Cup or you? Let's see if he responds. Now he's in St. John's, Newfoundland, so you know there could be, I guess, possible an iceberg blocking the signal. So Matt, thumbs up. All right, way to go, Andrew. Thank you so much. I appreciate that. All right, once again, thank you all very much. We have programs listed on our perfweb.us website for August, 2 programs scheduled, and I'm going to be sending out an evaluation to everybody who signed up for this program for the CEUs. As soon as I get those back, I get your certificate out to you. And please let me know if we need to bring Chris back for more discussions, because I think he does a fantastic job sharing. I love people that are not afraid to share their opinions. And that always makes this show a lot more fun for me and everybody else. So good night, everybody. Till next time.